Good afternoon. Welcome to everybody who decided to join us for today's seminar. Well, I see that the number of people connecting is still growing. We have decided to have this seminar in a kind of hybrid mode. So we have a number of participants here at the third floor of Sano. And well, together with, of course, together with the today speaker, who is Rosmary Blanco. And Rosmary is a PhD student at Sano, working in computational neuroscience team. However, before that, Rosmary obtained a bachelor degree in neurophysiopathology from University of Udine, Italy, and then obtained Master of Science in Molecular and Medical Biotechnology from University of Verona. And well, last year, Rosmary spent almost 4 months in Amsterdam at the team led by Henmarkering. And well, I hope that today's talk will be about some results of his research in Amsterdam. So, and as usual, if you have a question which is simply need to be asked in order to understand the talk, do this. But we will have a discussion after the talk. So, Rosmary, floor and screen is yours.
Great. Thank you, Marian, for this kind introduction. And yes, today I'd like to share the project I started during my internship at Amsterdam University Medical Center last year. And my talk will move from the foundational signal processing to the development of an uncertainty-aware model capable of safe decision-making in pre-hospital settings. Okay. During my internship, I was hosted by Professor Henk Markering, who is a principal investigator at the Department of Biomedical Engineering and Physics at Amsterdam UMC. And I also collaborated with Professor Jonathan Coutinho, who is a stroke neurologist at Amsterdam UMC, and Dr. Aneta Lisowska, assistant professor at computer science at the university. My work was conducted within the neurovascular disorders research group, which is a multidisciplinary team spanning neurology, neurosurgery, radiology, and biomedical engineering, and that share the same mission to reduce the global burden of stroke by both improving the pre-hospital stroke triage for faster access to reperfusion therapy and optimizing reperfusion treatment. I worked on a collaborative research project aiming at developing AI model to predict large vessel occlusion in the ambulance using EEG data within the framework of electrostroke and AI stroke clinical trial. And this project closely align with my scientific interest to do translational research, bridging neurology, biomedical engineering, artificial intelligence, and real-world application and implementation. So I am very grateful for the opportunity that I had to collaborate in this multidisciplinary project and collaboration. And I would like to thank my supervisor and mentors, as well as my colleagues at Amsterdam for their openness and fruitful collaboration. And of course, I'm also grateful to Sano for giving me the opportunity of staying in Amsterdam for 4 months. My internship objective was to contribute to this project through mostly EEG data analysis using this richly annotated data set. And during my work, I learned mostly which technical and clinical constraints most strongly influence data quality and model design. So my focus was at the beginning focused on improving EEG data quality by evaluating different artifact removal technique and implementing an optimal preprocessing pipeline that maximizes the accuracy in distinguishing ischemic stroke from stroke mimics. And of course, this work built a foundation for future research direction in clinically integrated AI. So far, the outcome of my project are manuscript under submission about this comparative evaluation of different artifact removal method, preliminary result of a second manuscript that was presented as a poster at conference KCCM last year here in Krakow about the comparative evaluation of the different denoising technique preprocessing used for pre-hospital stroke triage, and a very preliminary result presented as another posters at the Central European Biomedical Congress last year about the feasibility of our pipeline to detect LVO in pre-hospital settings. Now I'm working and preparing the second manuscript about uncertainty quantification for EEG basic stroke detection in pre-hospital settings. But let's start with the context of our research. So acute ischemic stroke is one of the leading causes of death and disability worldwide, affecting approximately 9 million people each year. And around 25–30% of acute ischemic stroke patients have a large vessel occlusion, so they are eligible for endovascular thrombectomy. However, EVT should be initiated as soon as possible to achieve better clinical outcome, and the recommended time windows is within 6 hours from the onset of the symptoms. But however, currently, the practice follow a so-called the drip and ship workflow, where a patient with suspected ischemic stroke is transferred to the nearest hospitals, and after the workup, if it's diagnosed having large vessel occlusion, is again transferred to a comprehensive stroke center for the treatment. Ideally, we can reduce this up to 2-hour delay that is so important for having a good outcome in LVO patients by directly transferring the subject having an LVO at the comprehensive stroke center, at the nearest comprehensive stroke center, while the other stroke case can be transferred to the closest stroke unit for the right treatment in that case. However, this workflow is considered one of the most critical logistical challenges in acute ischemic stroke. And why? Because to be effective, a pre-hospital LVO detection method have to follow almost all these requirements, having a high accuracy, speed, usability, portability, and should be affordable. And the current pre-hospital detection method addresses only part of the problem, and no one meets all these requirements. For instance, the standard clinical scale in ambulance are, of course, fast, simple, but having a poor specificity for LVO detection, or the mobile stroke unit, which is a gold standard in imaging, are so costly. Telemedicine is another option, but the accuracy for LVO is unknown, and also transcranial Doppler, which is promising in hospital, is time consuming. So, as alternative, electroencephalography is an attractive technique for pre-hospital stroke assessment because it directly measures cortical activity and it is high sensitive to cerebral hypoxia. Moreover, with advances in new neurotechnology, portable device with a few electrode can reduce the preparation time and can allowing for non-expert users. It is possible to completely automatize interpretation, processing, and interpretation, and they are relatively affordable. However, electroencephalography have some limitation and still open challenge. First of all, the reduced signal quality, mostly related to the use of dry electrode or the non-controlled environment in pre-hospital settings or in ambulance that increase artifact contamination. Moreover, studies are still ongoing to check the accuracy for LVO detection, and it needs robust automated analysis for getting reliable results. So while EEG offers so great promise for pre-hospital stroke assessment, its effectiveness ultimately depends on the quality of the signal recorded. So for any clinical application, that quality comes first. Because even if a signal, even if we have complex and more advanced AI model, if the signal is not contained in the recording, we cannot extract meaningful insights and information from EEG recordings. So, for example, like in this case, we can face hardware failure, so no signal is recorded. We don't have okay. So no signal is recorded at all, or most of the recorded can be affected by heavily artifact, or we can face with missing channels. So where the use of dry electrode this is mostly increased in pre-hospital settings, and because the use of dry versus wet electrode and the uncontrolled recording conditions. And moreover, there is no universal preprocessing pipeline that can be applied for each type of recordings, because the EEG signal has itself variability, intra and intersubject variability, depends on the number of electrodes used for the recording, the condition of the recording, if in resting state or during the task. And another limitation is that state-of-the-art preprocessing pipeline that are developed for standard or high-density EEG, so they are not suitable for low-density EEG, where the spatial resolution limited the signal decomposition for getting reliable results. So to avoid misinterpretation or invalid information, we need a robust data quality assessment and robust denoising before doing any other task with EEG. And the data set I used is a unique data set which combines two prospective multicenter studies, electrostroke and AI stroke. Both studies followed a rigorous design, where enrolled adults with suspected stroke within 24 hours of symptom onset. EEG recording were performed in ambulance or on scene by paramedics or in emergency room by expert research using 8-channel dry electrode EEG with a recording lasting 2 or 3 minutes. After that, the clinical ground truth was retrieved from medical records. So we have a lot of metadata such as demographic, medical history, medication, or other data coming from CTP or other imaging technique, neurological evaluation with NIHSS record, and the final diagnosis and treatment. So to assess the quality of the recordings in this data set, we first applied a minimal preprocessing consisting of standard filtering to remove line noise and slow drift from the signal. And after that, we cleaned the recordings from heavily contaminated segment of the recording by artifact using a global variance in temporal derivative, which is a technique usually used for fMRI and FMIRS, but that I applied for EEG successfully this time. After that, we detected and removed from the recording the bad channel, meaning those channels that were too noisy or flat, so not recording at all, and then passed the recording into a data quality check. If recording passed the quality check step, this bad channel were corrected through spherical interpolation. And for the quality check, after this minimal preprocessing, each recording was visually screened, and a recording was excluded if met one or more of these criteria. If there was a technical failure, so isoelectric signal or amplifier saturation, if there was evidence of more than 2 bed channels globally, or both the 2 bed channels located on the same hemisphere, or if after the removing of bed segment, the signal lasted less than 1 minute. And the final data set, the final pooled data set after this quality check comprised 719 subjects up to 1,027 subjects that were after that stratified based on the final diagnosis into 2 groups, 376 subjects having acute ischemic stroke and 343 stroke mimics, including cerebral hemorrhage. So at the end, we have also quite balanced data set. We performed the basic baseline characteristics of the 2 groups, showing that the NIHSS score was different between the 2 groups, with the stroke cases showing more severe stroke. So we started, also the clinical cohort patients was defined. The next challenge was to have clean data ready for the analysis. Thus, the last step of our pipeline was to identify the most effective artifact removal strategy, and we compared 3 of the most commonly used methods for cleaning EEG artifact in low density EEG. Namely artifact subspace reconstruction, which is a statistical method able to detect large and transient artifact, wavelet transform, that was more or less no time frequency decomposition, and empirical mode decomposition, which is an adaptive data-driven decomposition that extract oscillatory mode at different time scale, identifying artifacts based on their statistical or spectral properties. And we tested also combination of this method to combine the strength of the statistical properties and time frequency decomposition of the method. So very briefly, even if this method differ mathematically, they all follow the same underlying logic. Each approach starts by transforming the signal to make the noise separable. Then the noise is estimated based on the characteristics of the transformed signal, and it is defined as a threshold. And during the thresholding, the noisy component were removed or corrected, and then the signal is reconstructed back in signal space to produce the noising output. But rather than arbitrarily selecting a single cleaning method, we adopted a multi-level strategy to systematically compare all methods across increasing signal complexity. So we first used the simulated data because having a ground truth to quantitatively assess artifact removal, and then tested the method on a benchmark dataset with experimentally recorded artifact and 2 clinical datasets that were aimed to address the very challenge of the artifact removal, that are the pooled stroke dataset and the dementia dataset recorded in home care settings. And this comparison allows us to assess not only whether the algorithm are able to clean the data, but also if they preserve meaningful neurophysiological information in the recordings. And for the semi-simulated data set, a qualitative evaluation was performed by visually inspection of raw EEG signal and spectrogram. So we saw that large amplitude artifact related to ocular movement or high frequency component related to muscular artifact remain in the data set cleaned with the EMD method and artifact subspace reconstruction method, while wavelet transform performed better than all other methods, as also quantitatively demonstrated by an increase of the signal to noise ratio, showing higher correlation with the ground truth and reduced root mean square error in both time and frequency domain. For the benchmark and clinical data set where no ground truth was available, we performed a quantitative evaluation using a metric designed to assess the preservation of physiological EEG characteristics. So, for example, a general amplitude score that measure how much of signal was retained in the physiological range of plus minus 100 microvolt after removing artifact, and the dominant frequency score that verify if the peak frequency in the theta, alpha, and beta band was preserved after the denoising. And for the benchmark data set, almost all methods achieved great result, reaching 100% of removing high amplitude outlier, while for the clinical data set, specifically the stroke, the EMD wavelet method performed better, and the wavelet transform for the dementia data set. Oh, the dominant, same for the dominant frequency score. I can summarize this slide by saying that for both benchmark and clinical data set, and for all configuration of channel count, only EMD-based method led to upward shift of the slow frequency, while the other method aligned with the original recording, which was only minimally filtered. And this is a qualitative result of the benchmark data set that show the same trend as shown for the semi-simulated data set, with the residual high frequency component for EMD technique and oversuppressing signal for artifact subspace reconstruction in correspondence of very high amplitude artifact. Qualitatively, the same results were shown also for the dementia data set, where the wavelet transform performed better than all other methods. Also proved by ERP analysis, where the amplitude and the latency of the P3 component as shown at the bottom of this figure was well preserved and comparable with the original one. And we notice that after apply wavelet method, that the variability, the variance was lower for VT, the wavelet transform method compared to the others. And what about the stroke data set? saying EMD left some artifacts, while artifact subspace reconstruction over suppressed segment of signal where the artifact were of higher amplitude. So in general, we can say that the wavelet transform can work better than other method, mostly specifically for low density recordings. But we noticed in our stroke data set that wavelet tended to smooth characteristic EEG patterns related to some pathological conditions. For example, for epilepsy, wavelet smoothed too much compared to the other method, the typical sharp waves, or in a subject with deep cerebral hemorrhage, tended to smooth this diffuse rhythmic discharge, while EMD method tended to preserve this pathological and characteristic pattern. So, given that the pre-hospital stroke triage rely on rapid assessment and require good data quality, but that the denoising may remove critical neural signal, our question was how do different EEG denoising methods affect the classification of acute ischemic stroke versus stroke mimic, including hemorrhagic stroke. And we wanted to systematically compare these different preprocessing strategy, not looking only at the performance, but also looking at the clinical error that this specific method made in the model in its decision. And so our experimental framework is displayed in this figure, and essentially we designed a competition between the 6 of the different artifact removal methods, where for each method we extracted a rich set of features spanning from frequency and time domain, complexity measure, connectivity, synchronization, and the brain symmetry index. And we then used the automatic machine learning to find the best classification model for each denoising pipeline. And finally, we compared using a metric like AUC and statistical DeLong test to determine which pipeline performed better in this specific task of classification of ischemic stroke versus mimics. But why we opted for auto machine learning? Because we wanted to ensure fair comparison, letting the system build the optimal architecture for each data set. Specifically, auto prognosis automatically chose the best combination of data imputation, feature processing, and classification algorithm. And through Bayesian optimization, it explored many possible pipeline configurations, iteratively selecting the one that best perform on validation data. We designed this framework so that each candidate pipeline was tested using 5-fold certified cross-validation to prevent overfitting. Instead of a single model, auto prognosis combine at the end the top pipelines into a weighted meta-learning to improve stability and accuracy. And our analysis revealed something interesting because the meta learning from autoprognosis was related to the complexity and the noisiness of the signal. For instance, for well-cleaned data set like wavelet transform or hybrid EMD wavelet or artifact subspace reconstruction, the meta learning was actually formed by only one single model, meaning that if the signal is already clean, we don't need so a complex model to achieve a good result. To the contrary, the noisy signal like only filtered or EMD that still left a lot of artifacts in the recording required a more complex model, meta learning formed by three base models. And we finally fit our model, but instead of using a single training step, we performed a cross-validation ensemble strategy, training the model on 10 stratified folds to ensure robustness. Moreover, we introduced the calibration of the probability using an out-of-fold strategy and by experimenting with two calibration techniques that are plot scattering and isotonic regression, and for each pipeline letting the system automatically select the technique that minimize the Breyer score, which measure the accuracy of probabilistic prediction. At the end, the final calibrated prediction on the test set was obtained by averaging the calibrated probability from the 10-fold. And we can see from the calibration curve for each denoising method that most of them were follow closely the diagonal. That means perfect calibration, indicating that our estimations are quite realistic. And the calibrated probability distribution showed that the model maintained a strong separation between the two classes. As a result, as shown in the table, there was no so a lot of differences in metrics like accuracy or AUROC for between the different methods. EMD wavelet performed better than the other, mostly because of a sensitive achieved the sensitivity of 0.94, but even when compared statistically using the long test, only the artifact subspace reconstruction hybrid method with wavelet transform was different than compared to the other methods. So if statistically these methods are not different, can we rely on these metrics of AUROC, of accuracy, if we want to choose the right method for differentiate ischemic stroke? Are these methods clinically different? And to answer this question, we performed a clinical error profile analysis on the misclassification pattern across methods. In a pre-hospital triage context, we must prioritize sensitivity. because missing a stroke is worse than having a false alarm, right? And looking at this matrix, EMD wavelet missed only seven subjects, 7 cases. Furthermore, compared to the only filtered baseline and wavelet transform that in our previous work had very great result. Here, this method made more little bit more infarct, more stroke patients than EMD. But this analysis allowed us also to identify systemic biases in our data and in our model. For instance, functional neurological symptoms or peripheral vestibular symptoms or tumors showed low misclassification rate across the board. Conversely, acute events like transient ischemic attack or seizure or cerebral hemorrhage were harder to capture for all the model, for all the pipeline and data set, meaning that these conditions physiologically mimic the symptoms of ischemia. So they are challenging for the classifier to differentiate. So the clinical implication of this analysis is related to the transfer decision, which is misclassification of acute ischemic stroke as a mimic is dangerous, as sending an LVO patient to a local hospital delays critical reperfusion therapy. Therefore, EMD wavelet showed the superiority because it minimized the false negative. In ideal situation, missing few subjects for the correct destination therapy, but also the computational efficiency. So this analysis showed that cleaner signal reduces model complexity. And at this point, selecting the right method, the right pipeline, and the right model based on the hybrid EMD wavelet denoising method with very high results for differentiated ischemic stroke from mimics. We can say that in a safety critical scenario like stroke triage, a forced binary yes or not is not enough. It is dangerous when a model is ambiguous or when a model don't say how uncertain it is in making its prediction. So this led us to the next critical question that was exactly, does the model know when it is likely to be wrong? Most of the model and the system published or in the current literature lack of this self-awareness. I read a lot of paper with different model using EEG with the same pipeline of destructing features, only measuring the performance based on classical metrics of accuracy. But rarely I read a paper that honestly says when the model was not confident in this decision. So our objective was to implement a patient level uncertainty quantification, and most important and novelty was to define a rejection option mechanisms to transform the potential error of the model in an advantage for potential deployment of our model by flagging the uncertain and high-risk patient with warnings for specialist review. And what we did is to compute it as previously said, an ensemble-based mutual information method to decompose the risk of uncertainty. So first of all, predicted the calibrated probability of the model and using the EMD weblet, and as you can see here, achieving very good results, and then calculated the uncertainty as the total uncertainty, the entropy of the average probability. And this was the uncertainty of our model in make this decision for each subject. But we, after that, decomposed the total entropy because we wanted to understand the source of the risk. If this uncertainty is due to the noises still in the signal, so computing the aleatory uncertainty, or because of model disagreement, calculating the epistemic uncertainty. And by mapping in a 2D landscape these two types of uncertainty, we defined a safety threshold. So basically in this error distribution, where you can see the red dot in the right corner where aleatoric uncertainty is higher, this distribution allows us to establish a threshold that allow to differentiate on the left of this space the patients that are predicted with high uncertainty, with high certain, so the model can be act automatically, and it is sure in its decision from the uncertainty cohort on the right. So where the expert will be included in this decision. And we simulate this operating point by on our test set to quantify the effect of these rejection options in our model. And we what is highlighted is a trade-off. If we put the threshold at 0.8, like we did, for example, the model can cover accurately and with very high accuracy of 96%, approximately 65% of patients, meaning that the model can, the system can automatically predict, and we can trust our model because of this high accuracy for this percentage of population at the cost of missing 35% of patients that we actually are not missing because they were flagged for human review. But after that, to investigate the physiological limit of EEG-based detection, we conducted this final post-hoc analysis on the misclassified case. Our model already performed very well because up to 100 subjects, only 7 were misclassified in the cohort of ischemic stroke, but we don't want to miss any single subject. So by applying our thresholding and uncertainty analysis, the system was able to intercept 43% of this false negative, that because of higher uncertainty, higher entropy, meaning that in ideal and in a realistic situation, these false negative were not missing, but sending to a clinician, to a physician for further analysis and further check. But what about the false positive? Because in the case of stroke, we want to maximize sensitivity because it's more dangerous missing an ischemic stroke than having a false positive. But in our case, we have a lot of false positive, 25 subjects. And given that we don't want at the same time overload the hospitals with a lot of false positive, we showed here that applying the same rule of our rejection option, 23 out of 25 false positive were flagged as uncertain for external review. So in this case, the model can say, okay, my prediction is this one, but pay attention because I am quite sure that I'm wrong in this decision. To conclude, and sorry, I've been long, I'd like to present our vision for future work. So very, very simple. The idea is to implement a model with a cascade architecture that can mimic the clinical reasoning. So in the first stage, a first model can answer the question, is this actually an ischemic stroke or not? And this is the safety layer we just discussed. In the second step, among the cohort of ischemic stroke predicted, we want to check for severity, answer the question, this ischemic stroke is a large vessel occlusion or not? And the third question, for the third model in the cascade, should be, okay, this is a large vessel occlusion, but is still treatable or not? And this is the most, let's say, novel, but also most challenging task to do, because we want to answer this question by modeling a model that take into account the time. The current EEG model treat the EEG as static, but physiology is dynamic. So even if we see in our EEG recording the slowing or delta frequency band, the same slowing at 1 hour could be different of the slowing at 6 hours after an ischemic stroke. And we want to do that by using CT perfusion, like state-of-the-art imaging, and regressing CT perfusion volume directly from scalp EEG. I don't know if it is feasible, but this is just an idea. So thank you for your attention. And sorry if I've been so long.
Many thanks for presentation of your research. We have time for questions, for discussion. In the meantime, before we will see people who would like to take part in discussion. Well, could you explain from where you got all this data you use here? So it was data which were available at Amsterdam University Medical Center, or it is?
Yes, these are two data sets. Can I start from the beginning? Yeah. And this is a data set that at Amsterdam University are collecting in the context of two clinical trials starting from 2018. And there are two clinical trials, the electrostroke and the AI stroke, which is still ongoing, specifically for detecting, using EEG for stroke triage in ambulance. So they are recordings with a portable EEG device performed in ambulance and in emergency room.
And and this, so it was data which were collected before you have started to analyze them, yes. And because I'm curious if, for example, what the result of your research could somehow be implemented in collecting new data.
The data collection, if I well understood, is finished because also the second clinical trial was finished, but we had quite a lot of recording, more than 1,000. The problem with this data was the quality of the data because of the challenging conditions of the recording and the device. I know that I'm not the only one working with this data, and soon we will have a meeting to share our model, our approach, and our results, and try to converge in a unified structure of the processing for this.
Understand. So it will be a kind of putting together different approaches and finding which results are really more, let's say,
more reliable, more deployed,
and also probably which of these approaches can give answer quicker, yes, because the time is a problem in all this stuff, yes.
Yes, exactly. And this is actually the main problem apart of the data quality of EEG, because many of my recordings are at 1-2 hours after the initial symptoms, because they are collected in the very acute stage. So we actually don't know, because there is not so a lot of paper published with EEG showing that this characteristic brain asymmetry index or slowing and other characteristic matter that differentiate ischemic stroke at this early stage are still represented in the signals or not. And this is actually something very interesting that I'd like to try with my model, because after uncertainty based on which is patient specific. Another interesting question could be for what feature among all this comprehensive set of features, I extracted my model is more reliable or not. And this could be an improvement, I don't know, with ablation study, for example, to be specific in what marker we want to say, okay, with EEG and this specific biomarker, we are sure that this is patients with ischemic stroke or LVO, for example.
Yes, and could you comment about to which extent this way of analysis of data is universal in the sense that it, because here you have used it to this specific type of a stroke, yes? And other diseases which can, for which you could apply the same approach?
The same approach. We can apply the same approach, but yes, exactly. Checking if it fits with other diseases, for example. Because, for example, also in this data set, we have many cases with epilepsy or transient ischemic stroke or cerebral hemorrhage. Not so a lot of cerebral hemorrhage, but still some cases, yes. That my approach and my classifier miss it. So I think that we have to develop a specific pipeline for each specific clinical question, starting from signal processing to developing the right model. I don't know if using deep learning and AI instead of classical machine learning, things could be different, but in that case, how we can explain and extract what are the biomarkers that differentiate these pathologies. Because in this case, we have a well-established biomarker that a clinician can trust, can recognize as for ischemia or cognitive impairment in other cases.
Yes, I understand that, and how the result of this analysis is going to clinician, and it is the clinician who decides finally what to do. I'm trying to look at the list of online participants. If there is someone who would like to ask a question. I don't see at that moment. Maybe it will come. It's here in the room. Somebody willing to ask the question or to discuss with. Oh yes. In the meantime, we have Wiesław who would like to ask the question. Wiesław, I think that you can.
Okay, thank you, Marian. I think you have focused on large vessel occlusion. Do you think it's possible to distinguish between ischemic and hemorrhagic stroke?
Yes, I think it is possible to distinguish it because with EEG they have very different patterns. I'm not sure in this so early time frame of 1 or 2 hours after the initial symptoms, but usually hemorrhagic stroke is worse. So the EEG signal, expected that will be affected severely and sooner than ischemic stroke. I didn't perform this analysis because in our data set we have only 35 subjects with hemorrhagic stroke compared to 700 ischemic stroke. So I included this cohort in the mimics cohort, but I honestly tried to classify them, but it was not. I didn't achieve the good results because the data set is really unbalanced. And I don't remember the other question. Sorry.
No, it was only one question.
Okay.
Thank you.
I know, yes. You mentioned I have to focus on LVO. Yes, this is the final goal. But as I can explain, instead of having an approach of multi-class classification, I think that developing a cascade model can help also clinicians understand how the model actually works. By answers and mirroring their clinical workflow and their routinely diagnostic process in asking first if this patient is having an ischemic stroke, then okay, but it is LVO or not, and lastly, can we treat it or not, can be a new approach to for this problem.
Wisław, thank you very much. We have Joseph with question or willing to take part in discussion. Joseph, go on, please.
Hi, can you hear me?
Yes.
Okay, yeah. So thank you, Rosmary, for this very extensive work. Well done. I think it creates a good narrative on the signal processing, essentially. So how difficult it is to use signals to take decisions.
Sorry, just if I'm interrupting.
We have a problem to understand. There is some, let's say, some noise. Could you please repeat your question once again?
Can you hear me now?
Yes.
Okay, so yeah, so from what I see in your presentation, you took a lot of time on the signal processing side, trying to collect the informative context from the EEG. So if okay, and that took you to have 65% of the patients detected with 96% of accuracy. Okay. But still, you have 35%, if I understood well, from the uncertainty that you try to cover, right?
35% people, meaning the coverage after applying the rejection option at the defined threshold, that automatically the model
referred to the doctor.
Yes, exactly.
Okay, yeah, so.
But this was actually trying to find a threshold. We can, of course, increase or decrease the percentage of coverage by moving our threshold of uncertainty higher or lesser. It is a trade-off. So
yeah,
here,
of course, everything in life is a trade-off. So yeah.
Yes.
So because so the thing is, there are nowadays two things that are really discussed on the AI scenario. That is, performance against competence. Okay, so we have a very good performance, 90% of accuracy in certain cases, but how competent is the model on really doing the job that we are trying to do? So I think. And also from the data set that you showed, I think that you mentioned that you also had clinical data on those patients, right?
Yes, exactly.
So why didn't you start to look into the explanation why this accuracy also are these 35% uncertainty that you are still unable to catch related with the clinical data that you had for those patients?
I tried to do that, but with only 7 missing cases, 7 false positive, I didn't find any correlation about, I don't know, evidence of hyperperfusion in CTP scan or any differences from missing or flagged or not flagged subject related to the time onset of EEG related to the onset of the symptoms or the location. For example, I checked also if the location of the infarction could explain why for some subject uncertainty was higher, for others no. So I started doing this analysis, but actually I didn't get any reason why for some subject. Maybe the problem is itself in the data. Indeed, the most higher uncertainty was the aleatoric one, so related to the data, not to the model.
Okay. Also, in during one of your slides, you presented that you said you demonstrate that you use auto machine learning to extract the features, right?
No, sorry, could you repeat, please?
So in one of your slides, you mentioned that you use auto ML, okay,
Yeah.
to extract the features. If I got it right? Okay.
Not to extract the features. I before extracted features from the denoised pipeline and then applied auto machine learning model with this WR data with the feature extracted.
Okay. So did you find any similarity on the features that were extracted?
Honestly, I didn't check. But what do you mean for similarity? Sorry.
So, for example, one of the things that is relevant is, you would like every time you do an EEG in a patient, that the features that are emerging as a classifier, which tells you that the patient is having a problem or not, are stable across the decision-making model. Okay.
Yeah.
So you didn't look into that, or how similar? So if the model was providing you similar features or not?
No, not yet. I didn't check yet. No.
Okay. Yeah. So thank you, Rosmary.
Thank you, Jason.
Thank you very much, Jose. Okay, then I see that there are no more questions, and we have almost reached the time devoted to this seminar. So, Rosmary, many thanks for your talk. And we are very grateful to Wiesław and Joseph for taking part in discussion. And I hope that all of this research will result in something what will help people survive after such a disaster like this type of strokes. Yes. So thank you. And thank you for participation in today's seminar. We will meet in 2 weeks from now on, I think that it will be the 2nd of February. There will be a next seminar, but you will see announcement of this. So thank you very much and goodbye.
Bye, thank you.